Okay, monkey. Thank you, monkey. And then I go here, and then I do pop out chat again. No, live chat is working. You're lying to me. Come on, monkey. Monkey with wrench. Make it pop up, please. What is this stupid monkey pop-up thing? Okay, now if I edit, customization, public, stupid monkey, public, done, restrictions, none. Doo -doo 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 -doo. Okay, changes saved. Now monkey, disappear. Come on, monkey. Boop, boop. Holy moly, and I got this cat going on in the background. Why is it not working today? I like having the chat there. Doo -doo -doo. Monkey, get off my screen. Refresh. Oh, I don't know what I just did. Oh, monkey. You thought you could block my live chat. You thought. But here we are. Monkey see, monkey do. Okay, we should be good. Hello. Do you see a monkey or my chat? What do you see? I believe I've nailed it. I believe I 100% got it this time. Let me know, fellas, when you're here. Oh, that was tough. That was tough. Hello, hello. Can you see me or a monkey? Can anyone see anything besides a monkey with a wrench? Let me see here while I'm doing this. I have this going. I'll click here. Refresh. This is probably going to lag the crud out of my computer. Whoa, whoa, whoa. Slow down, slow down. Get me out of there. I can, in fact, see with my ocular tools. Bio Big Daddy, I'm so happy to hear that. I'm so happy to hear that. Beautiful. I was so worried that we would be stuck on the monkey scene only. Okay, what's on today's docket? What's on today's planner? Well, I do a first come, first serve kind of basis. Yesterday, we talked about doing some practice scenarios, which I think is super fun. But if anyone else has any request beforehand, let me know. Any request? Any questions that you may have as a viewer, an ocular viewer with ocular tools? Let me know. I'll answer anything to the best of my ability. Or I'll start spouting nonsense. While this is going on, let's take a copy. Hello, Burner. So good to see you, Burner. I'm so happy to see you. Do you like Mac or Miller Blades? Excellent question. I am a Mac guy, 100%. I think that it's very good. Let's see. How do I get into this group here? Hey, everyone. I'm going live for free tutoring. If anyone's interested or have any questions, feel free to jump in. Sorry, guys, I got to do this little mini self promote. Post. I don't know if I'm allowed to do that, but I did it anyway. So Zach Pope is asking about Mac or Miller blades. So let's take a little looky-loo at the difference between the two of them. Mac blades. The Mac blades have more of a curvature to them. Let's see here. So it's going to look something like this. And he says he likes Miller blades. Miller blades look something like this. Miller blades will look like a straight blade. Uh, some people say that Miller blades are good for pediatric patients, and Mac blades are good for just general adult patients or large patients. But it's really up to you. There are extremely talented CRNAs and paramedics that can utilize both without any issues. And let's see, Bio. Oh, what's up, Yoke? So good to see you. I remember the nickname you told me to say. And then Bio Big Daddy says, I'm just starting out. Found your study guide video. Do you have any recommendation on additional material I should get while continuing with your videos? Bio Big Daddy, that's an excellent question. What would I recommend? I'd recommend amateurmedicine.com. And usually I like to end every single live stream by going over a couple practice questions on it. But it's a test prep that we made that has a couple different tools, and I can actually show it right here. It's very fun. Let me pull it out. You personally, oh yeah, I just read that. So what does it include? You get access to 60 plus questions for the GCS APGAR and Rule of 9. You get 120 plus practice questions practicing your vital signs, which is imperative if you want to pass the National Registry. You get 500 practice questions and 5 practice exams that are fairly relevant. I could fluff it up and I could add more questions, but at a certain point, you're kind of wasting your time, right? Like, do you really need to know about metabolic acidosis? Yo, don't worry about it. I completely understand. Do you really need to know certain things, or should we just get to the meat and potatoes? So I made it specifically to questions where I figured you're probably going to get asked this, and then you should be good. And then there's also the 2-hour updated study guide, but with it, you also get access to what it's called. You get access to a filled out PDF, right? So I can even give you a little glimpse. And so every single, what is it called? Every single course, you also get access to a Discord channel. It's the same exact one as here. And you can ask questions about the person who made it, which was me. So you can ask it any questions that you may have. You get a master copy too, right? So not only do you get the student copy that's empty, but you also get a master copy that has like filled in information. So if I go over here, like instead of having to fill this out, you actually have the complete filled out version and you can just download the PDF here. So it's really nice. How's nursing school going? It's going great. I've been passing all my exams. One of my biggest ways how I pass is by going to tutoring. And so I go to tutoring just about at least once a week. During the summer, I was going twice a week, but I really only have time for once a week. No problem. And I think it's pretty reasonably priced, Bio Big Daddy. But if you have any questions, again, you can join the Discord in any of our descriptions on videos or via the courses, and you can ask any questions that you have or join a live and ask any questions. But yeah, nursing school is going great. I'm passing all my classes. Clinicals are kind of long. The only issue is that they have 9 pages worth of clinical paperwork to do, which is dreadful. Uh, I would rather not do 9 pages per patient, or I think it's 8 pages per patient, but I really enjoy it. I'm planning on doubling up as a firefighter paramedic, so this is huge for me. Fantastic. Uh, Being a firefighter and a paramedic is a lot of fun. I work 48 hours and 96 hours. And so what does that entail? 48 hours is 20, I need a copy of 2. Is 24 hours on the medic unit, 24 hours on the engine. So you get a day where you're thinking pretty hard over like medic unit stuff, and then you get a day where you can use some physical energy, right? Or you can kind of get some stress out and you can work pretty hard on the engine. So it's a good mix up so you're not burnt out, in my opinion. Let's see, can you go over cardiac emergencies and maybe some acronyms to help determine the nature of illness? Okay, uh, that's a great question. So, Zach, I'll start with this. Zach is asking about cardiac emergencies. Okay, so if you're worried about cardiac emergencies, I will ask all of you this, which is very relevant to know. What are some cardiac medications we can administer in EMS? Does anyone know? What are some cardiac medications specifically for chest pain? I'll say that. Okay, so we have nitroglycerin. Nice. What else do we have? We have aspirin. Okay, nice. Anything else? If you're a paramedic, you actually have access to something else. 324 of aspirin, exactly. Oh, hey, RDL man, good to see you. Oxygen, right? Some people like to reference oxygen as a medication. That's okay. I try not to add it too much just because I don't want to, what's it called? I don't want to get it kind of confused, but I can agree with that. AMT level for me, morphine for paramedic, right? For paramedic, morphine. Exactly. Okay. And so if we have a chest pain patient, we can consider these medications. Now, some people like to memorize it as the acronym MONA, right? Which just means morphine, oxygen, nitroglycerin, and aspirin. That usually works for them. Now, out of these 4 medications, as long as they're not allergic to it or have like any contraindications, what medication do we want to consider administering first out of these 4? Which one usually always goes first? And I'm going to take out oxygen just to not confuse things. So, oops, I'm going to type this in the chat. If we have aspirin, nitroglycerin, and morphine, which medication goes first? Aspirin, maybe? Okay, we got 1 aspirin. Anyone else have a guess? Any other guesses? Burner says aspirin. Nitro prescribed. Okay. So the answer choice is going to be aspirin should go first. Okay. Why do we want to administer aspirin first? Well, basically what's going on is we have our arteries, right, that are feeding our heart. And with long-term plaque buildup, we're going to color plaque like this just to make it easier, right? We're going to see this occlusion kind of building up. Your body's going to see this, and it's going to say, hey, it's going to notice that the plaque is sticking onto plaque. And so what can the body do? Well, it can't remove the plaque buildup. So instead, it's going to build up some platelets around the area and kind of calcify around the region to stop it from getting any bigger, okay? And that'll help, but the issue is every time we do something like this, it starts to cause further and further occlusion. And let's say you have a cardiac event where, like, let's say you're working out really hard or you have some issue where these vessels burst right here, we have an opening. The body will see this as part of their tissue opening up and getting injured. And what's it going to do? It's going to form more platelets around the region. And so platelets are going to kind of build around this region to calcify more, right? And if it becomes big enough, then it's going to slow blood flow from returning to the heart, right? And if that's the case, it's going to cause a myocardial infarction or a lack of oxygen to the muscular tissue. Part of the heart, let's say if this is the heart expanded, which is not how you should look at the heart. And let's say this part of the heart gets cut off of blood flow, then what's it going to do? The cardiac plexus that forms around the heart is going to stimulate a vagal nerve response, screaming, help, help, I'm not getting any oxygen. And you're going to get that horrible chest pain. So what can aspirin do? Well, it can't break up any clots, right? That's more so for heparin or other hospital drugs that we don't have access to. But instead, let me see if I can clear this up. Get out of here. That looks horrible. Can I make this bigger? So let's go ahead and clear this up. Get out of here. So what is aspirin going to do instead? It's going to basically stop this plaque formation that's building up right here. Right, so it's going to stop this from occurring, and it's going to stop the narrowing caused by the platelets. Okay? And that will, basically, aspirin stops the problem from getting any worse. That's why we give it early on in chest pain calls. Now, what can nitro do compared to aspirin? Well, nitroglycerin will vasodilate, right? And if it vasodilates, it opens up the passageway to the heart more. So nitroglycerin and morphine will do the same thing. It'll actually take the borders that are feeding to the heart, and it'll make it a little bit bigger whenever we administer nitroglycerin. And so we give aspirin to stop the problem from getting any worse. We give nitroglycerin to open up or vasodilate and reperfuse the heart. And so it kind of, there's like a little combination therapy that we can do. Now, what's the issue with nitroglycerin? The issue with it is that if somebody has hypotension or they have if they're on an erectile dysfunction medication in the last 24 hours, then they can't take the medication, right? Because we're going to potentially bottom them out. So let me see if I can find good imagery here. Water slide with no water. It's basically going to be, this is how I like to visualize it. I want to find a water slide with no water. With water hose. Show me. Basically, if somebody, why do we give morphine? It does the exact same thing. And so, if we have our vessels here, right? If somebody is hypotensive, we're probably not filling up the, We're probably not filling up the vessels as much as we would like if they're hypotensive. And so, what would we see? We would see, what the heck? Can I get a good, like, paint or something? We'd probably see about this much blood, right? And so this can't properly pump to the heart. And so if we vasodilate and their vessels aren't filling up all the way as is, we run the risk of not feeding enough blood to the heart. And if that's the case, then the heart's going to start pumping with less than like a full amount of blood. It's going to cause it to go into a cardiac arrhythmia and potentially go into cardiac arrest. Morphine and nitroglycerin basically do like a very similar function, where they're both for pain relief and they both are going to cause vasodilation. So let's expand this a little bit. Aspirin goes first to stop the problem from getting any worse. Theoretically. Now, it doesn't completely do this, but that's the whole plan, right? Nitroglycerin and morphine vasodilate. They reperfuse the heart. I think I misspelled it. Reperfuse, right? They perfuse? Why can't, no? It doesn't know, whatever. It reperfuses the heart. It helps go around the obstruction. What's an issue with morphine and nitroglycerin? If you don't have enough blood flow, and then you're pumping to the heart, and now the right atrium is not getting enough blood, so the right ventricle is not getting enough blood, and so forth, we end up causing them to go into a cardiac arrest, right? So we have to be really careful with morphine and nitroglycerin. So for anyone who's working on the box, what do we need to set up before we administer nitroglycerin and morphine? What should we be assessing for before we administer this medication? Opinions on nitro and inferior wall MI. Some say it's dogma to not give it at all, and the original study was not great. Okay. And you're absolutely right, by the way, RDL. Burner, that's a great question. What do I say? Before you administer nitroglycerin, this is more so for ALS. It depends on your protocols, but don't get too confused on this, especially if you're taking the EMT-B. This is for more so EMT paramedic. Before you administer nitroglycerin, you better have a 12 lead. You better have an IV and a saline bag set up, especially for an inferior MI, right? Because an inferior MI or inferior myocardial infarction, if you give them the nitroglycerin or the morphine and it causes increased vasodilation, and then you dump their blood, then you can potentially cause them to become extremely hypotensive. So have a way to reverse it. Have an IV and a saline bag set up. So what do we need to set up beforehand? Let me see if I can take this 2 here. We need a 12 lead. We need to assess the patient's vital signs, and check their blood pressure. We need to check if they are on erectile dysfunction, RXs, in less than 24 hours. Some texts will say 48 hours, but 24 hours is the golden standard, right? So we need a 12 lead. We need to assess their vital signs, make sure they're not hypotensive. We need to check their blood pressure. We need to make sure that they're, if they're on an erectile dysfunction medication, the last 24 hours. What else do we need to know? EMTs and paramedics. What do we want to have? We want to check out their ETCO2 also, right? It's always good to have extra measurement tools, especially when we're onboarding any of these complex medications. And then when we administer these medications, let's say you administer one of these 2 medications, either nitroglycerin or morphine. What do we do next? What's the next thing you're going to think in your head that we should do? Let's say a minute's passed, you've given nitroglycerin or morphine for this chest pain. What can we do next? What's the next thing you do? Reassess. Exactly, Zach Pope. We reassess. We check, exactly, RDL. We check their blood pressure. Exactly. We look at their EKG. We check if the patient still has chest pain. Right? So if we decided to administer nitroglycerin for the chest pain, we administer 0.4 milligrams, also known as 400 micrograms. Sublingually, we administer it under the tongue, right? If we're doing EMS. In the hospital, there's a bunch of different routes, but in EMS, we know it as sublingually. When can we administer a second dose? A minute after, if nothing's changed? 30 seconds? Any guesses? When can we administer a second dose if we administer the first dose for nitroglycerin? 5 minutes? Okay, that's a really great guess, RDO. 3 to 5 minutes? That's an excellent guess, Zach. Anyone else? We administer it every 3 to 5 minutes. Exactly. So 5 minutes is a good answer, every 3 to 5 minutes, and lean more towards 5 minutes, especially for your first dose. We say, "Do you still have chest pain?" Yeah, my chest pain went away, and like a minute passes, and they're like, "Oh, it's back," and it's like a 9 out of 10. Okay, we can administer this medication again after like 3 to 5 minutes. But in between our doses, of course, we're rechecking blood pressure right before we administer it. We're reassessing the patient. We're making sure their vitals are still stable because we don't want to drop or crash their blood pressure. And if we do, we want a way to reverse it. If we have an AEMT, a paramedic, or depending on your protocols, we can start an IV and set up saline. Or we should have an IV already set up. We can administer saline. A lot of protocols will not allow you to administer nitroglycerin as an EMT-B. The reasoning is you can't determine if it's an inferior MI or not if you don't have EKG skills, and you technically don't have the skills to start an IV, although you can get that later on in agencies. So it's tricky. Okay, so we administer it every 3 to 5 minutes. What is our max total for nitroglycerin? And what do I mean by that is, when are we like, okay, we've administered this medication enough times, we cannot administer any more of this medication? If we administer nitroglycerin. Zach says we can give 2 doses. Burner says we can give 3 doses. Excuse me. So we can administer nitroglycerin 3 times for a total dose of 1,200, and it does depend on your protocols, but generally it's 3 doses. I've never seen it not be 3 doses. For a total dose of 3,200 micrograms or 1.2 milligrams. Okay? And that's what we should be expecting to administer for nitroglycerin. For morphine, paramedic only, we would consider administering 2 to 10 milligrams of morphine, depending on your local protocols. And we would usually cap out, I'm guessing, at like 10 milligrams at max. I couldn't see somebody going past 10 milligrams. Really classic thing that I like to personally administer as a paramedic is I like to do 4 and 4. This is how I like to treat pain. It's 4 milligrams of morphine mixed with 4 milligrams of Zofran or ondansetron. I love administering this little mini cocktail. I find that it works really well because you're combating the pain, you're combating the nausea that comes with morphine all at the same time. And so this is my favorite little cocktail, like a 4 and 4 for pain management in EMS. Giving morphine without Zofran should get you. Oh no, it's okay, Burner. There isn't there like there's some weird thing. I've met one patient recently who is actually extremely allergic to Zofran, like life-threateningly allergic to Zofran, and I didn't even know that was like possible. But yeah, for the most part, if you're administering morphine, consider administering Zofran right with it, and then afterwards follow it up with a flush. You usually want to do this IV, although some places let you do it IM. I'm able to do it IM or intramuscular, but intravenous is an option. So we kind of went over this, and now I'm going to give you guys a little patient. Okay, you have a 36-year-old male patient who is jogging outside for 30 minutes. He went inside because his chest pain was a 10 out of 10, and it hasn't gone away 20 minutes. No, we'll say in 10 minutes. What you are dispatched to their residence, what should you do first? What should we do first? If we are dispatched to a residence and this is our call. So you have a 36-year-old male patient. They were jogging outside for 30 minutes. They went inside. His chest pain's a 10 out of 10. It hasn't gone away in 10 minutes. And you're dispatched to the residence. What should you do first? Any guesses? Assessment, HPI, full set of vital signs. Ask him what type of pain he's having. Where specifically? Okay, so if we're doing this EMS scenario-wise, the first thing that we're going to do is we're going to do BSI, body substance isolation, put on gloves, and check for scene safety. While I'm on the way to this call, this is just how I'm thinking about it in my head. I'm not saying any of you are wrong, by the way. While I'm on my way to this call, I'm requesting. It's okay, Bernard. Don't worry about it. I know we're not sinking in. Like I might be seeing it this way. You're thinking of it that way. While I'm on my way to this call, I'm requesting for additional resources. Don't worry about it. I'm gonna get to what you guys talked about in a moment. Okay. So I'm requesting additional resources like an engine company or like 2 or 3 other people to help work with me on this because it's a cardiac call. You guys say, ask what type of pain he's having, assessment, HPI. HPI is kind of a general thing that we don't really go over too much in EMS. That's more so clinical wise. Full set of vitals, where specifically it happened, why this happened. Okay, I see what you guys are asking. Okay, but if we're kind of working down the list, and I don't think you guys are wrong for what you said, Werner and Zach, so don't worry about it. I'd go up to the patient. I'd introduce myself while assessing their airway breathing circulation. No, assessing their level of consciousness and their airway breathing circulation. Right? So I'm talking to them, they're talking back to me. Let's say the patient is ANO times 4. Okay? He's responding to me appropriately. And he's able to answer all my questions. So then you said, ask what type of pain he's having. Okay, we'll start from the list right here, right? And so whenever you tell somebody that, what kind of acronym are we thinking of when we're looking for the type of pain a patient is having? What's a really common acronym? What acronym can we use if we're looking at the type of pain that a patient's having? So what acronym, what acronym, sorry, I accidentally clicked a button. What the heck? What the heck? What did I do? Burner, message deleted. No, I didn't delete it. What did I click? I don't want to hide the user. Oh, hold on. What did I just do here? I clicked a button and it went and then it like removed all of Burner's messages. Burner, oh my gosh, I'm so sorry. Can you still talk, Burner? Can you still talk? I'm so sorry. What the hell did I just click? View. I didn't mean to click this. Burner, I'm so sorry. He said, I've been silenced. Can you still talk, Burner? Did I completely screw this up? You did say OPQRST. Oh no. I tried to type while doing that, I'm so sorry. I don't know what happened. My fault, Burner. The genius Burner says OPQRST. Sorry. Means onset, provocation. Sorry. Radiation, severity, and the time that this occurred. Okay, so if we're talking to, sorry, if we're talking to this patient, and good to see you, garbage brain. I'm a little frazzled, guys. I did not see that coming. Okay, but onset, what occurred? The patient is complaining of chest pain. Okay, provocation, it started when he was jogging, hasn't gone away since. Quality, the pain is a 10 out of 10 on the pain scale. The chest pain, by asking radiation, the chest, like, sir, does it travel anywhere? The chest pain travels to his left arm and his jaw. That's very bad, by the way, guys. Severity, the pain, like, if I was assessing somebody's severity, I would say, sir, what type of pain are you having? Are you having, like, I think I mixed up severity and quality. Oops. Just a little frazzled by what happened. I normally like to ask a patient, is your pain sharp, numbing, throbbing, pulsating, tingling, dull? How does your pain feel? And they would say something like, his chest pain is sharp. Okay? And when did this occur, sir? This occurred 45 minutes ago. Or we'll say 40 minutes ago. Sure. Okay? Man, I don't understand what the heck I clicked for you, buddy. I'm sorry about that. Anyway, so that gives us a good answer or a good idea of what's going on with our patient by using one of our two acronyms, OPQRST. Sample is a great one too, right? So let's travel upwards. We ask what type of pain he's having. This is all your general assessment. Then we want to check an assessment, HPI, full set of vitals. Okay, that's we're going to kind of skip that for a little bit. Where specifically it has happened before, okay? So we're going to ask the patient, kind of like what Garbage Brain was asking. Sample. Question in my mind, provocation is, does anything make the pain worse? An onset be started when jogging, is that incorrect per se? So when we look at OPQRST, let's see. Let's see. So another way you can ask onset is, when did the symptoms start and what was the patient doing at the time? And so the patient is complaining of chest pain. Oops. Right. It started when he was jogging, hasn't gone away since. You're absolutely right. My fault. And the provocation is, what makes the symptom better or worse? Nothing has made the pain any better. It's worse when we'll just leave it at that. But you are absolutely right, Burner. My fault about that. So the patient is complaining of chest pain. It started when he was jogging. It hasn't gone away since, and nothing has made the pain any better. The next thing that we have, let's see here, is sample for our patient. So we have sample. That's signs and symptoms. We have allergies. We have medications, past medical history, last oral intake, an event. Okay, the event that occurred, the patient was jogging when he experienced chest pain. The signs and symptoms, I mean, the patient is just experiencing chest pain. It's very simple. Allergies, no known drug allergies, or NKDA. The patient's medications, the patient takes a baby aspirin in the morning. They take, what else is it? Simvastatin, metformin, and gabapentin. Past medical history, I can just tell from the medications that they take. They have hyperlipidemia, which is just like elevated cholesterol level. They take metformin, so I'm guessing they're either type 1 or type 2 diabetic. For this instance, we're going to say they're a type 2 diabetic. They take gabapentin, which is just for neuropathy, or just like nerve pain, which may be in conjunction with the diabetes. And they also take a baby aspirin. They've had a heart attack in the past. Or they have, let's see, where's that? They have 2 stents in place. Their last oral intake, they ate a taco 2 hours ago. Okay. So we have all this information, right? So I know that you kind of mentioned it, but I kind of skipped over it because it had a lot of stuff. But we've asked our OPQRST, our sample questions. What can we be assessing while asking these questions? What can our partner be obtaining while we're doing this? Does anyone have any idea? And one of you already mentioned it. Vitals? Okay, that's perfect. Vitals, ABC. So we already got ABCs out of the way because the patient's talking to us. An EKG, I agree. Okay, so what vitals do you want? What vital signs do you guys want? And I agree with an EKG as well, but that's more so for AEMT paramedic. They're able to obtain it and the paramedics can interpret it. What vital signs do you want? Okay, you got a BP, or you're asking for a BP, you'll get a BP. 146 over 74. You're asking for an SpO2. Okay, that's going to be 95%. What other vital signs do you want to know? Capnography. Okay. ETCO2. This is more so for AMT and paramedic. We're going to say that it's at 41 millimeters per mercury. You say a blood sugar, so blood glucose. You're going to say blood glucose. We're going to say that that is at 86. You said a respiratory rate is going to be at 16 breaths per minute. Is that all the vital signs you want? That's all the ones that you've given me. Are we missing any vital signs? Pulse, okay. Heart rate, 104 beats per minute. Temp, if you desire. Yep, I'm just looking to see if you know all your vital signs. And temperature, yes, excellent work. We're going to say 98.3 degrees Fahrenheit. We'll just use Fahrenheit here. Okay, and so this is how our patient's presenting. What is abnormal out of these vital signs? What makes you say, something may be going on? And you know, we'll bump this up to 20. The blood pressure. So the blood pressure is elevated at this time. They're hypertensive. It's greater than 140 over like 100, I guess, or 140 over, doesn't really matter. Is hypertensive. Heart rate slightly. Okay, I agree. The heart rate is elevated. Heart rate is greater than 100 beats per minute. The respiratory rate is normal. Okay, the respiratory rate Normal range is between 12 to 20 breaths per minute. Okay? So I completely understand what you're getting at, by the way, Zach, how the respiratory rate is still on the higher side. It is, but it's still within the normal range. So you really want to get into the habit of just being like, oh, it's normal. Okay. And then move on. Okay. Because it is technically still normal. You know, or like an SpO2 at 100% versus an SpO2 at 95% mean the exact same thing. They're both normal. Increased work of breathing, not really. Technically, their respiratory rate is still within the normal range, but their heart rate compensating for the increased O2 demand, I agree. And in real life, how would the patient actually be presenting if this wasn't like a textbook question? It would probably be like a respiratory rate at 24 breaths per minute or 28 breaths per minute. But this is how our patient is presenting. You ask for an EKG, okay? Let's see. I'm going to give you an EKG in a second here. This is a good one. I pulled this up from Helio. Clammy skin, yeah, we're looking for diaphoresis, right? So, this is your EKG. A lot of you don't know how to read this yet. That's fine. Don't worry about it. What looks abnormal here? But yes, clammy skin, also known as diaphoresis. Let's see. And I'm trying to find a good imagery. This is on YouTube, a thumbnail. These are our regions, by the way. There's ST elevation, right? This one guy on YouTube made this, but it's very good. Basically talks about where we're looking into like the heart, for instance. So 2, 3, and AVF are inferior leads. They're right here. So we'll look at 2, 3, AVF. We look at the septal leads are V1 and V2. Our anterior leads are V3 and V4. Our lateral leads are V5, V6, 1 and AVL. So V5, V6, 1 and AVL. And then our AVR is nonsense. Let me see if I can find a better one, actually. Because I don't really like this one too much. Let's see. Let me see if I can find a better EKG, guys. Because this one's good, but it's not necessarily what I'm looking for. They're calling it this. This isn't correct. Let's see. This is a better one. No. Come on. Show me one that's just this thing. Sorry, guys. I'm looking for a really good EKG here that I can utilize to teach you. This one's okay, but it's going to confuse you guys a little bit more than I like. We'll make it easier. We'll just pull up one of these. Copy image. We're swapping the EKG out, fellas. This will be easier to teach you. Here we go. QRS is wide. I can only read 4 leads in my scope. Don't worry about it. Okay. I'm going to teach you guys real quick. Okay. This is our EKG. And what is a STEMI? A STEMI is ST elevation causing a myocardial infarction. Okay, that's what a STEMI is. And so, PQRS T wave. And so, this is what a lead should generally look like. Now, there's a couple exceptions, but for the most part, this is what they should look like. And what do we have here? We have the P wave, which is right here. That is the atrium compressing. We have the QRS, so our QRS. And then we have our T wave. All right, so the QRS is the ventricles contracting and the atrium relaxing. Then we have our T wave, which is the ventricle relaxing. So it should look something like this. And what does a ST elevation look like? It's whenever the S and the T kind of merge together. So it's going to create kind of like this hump right here, right? Because S and T are elevated, causing a myocardial infarction. So we would look for a somewhere on the EKG where it's like, no, let me draw. Let's see if I can do this here. Beautiful. We would look for a P wave, then we would look for Q, R, and then for the S wave, the S and the T merge together, and then it goes from there. So then we start with our P wave, our Q, R. Sometimes we're not seeing Q, that's fine. Then we have our S, which is this hump, and then it keeps going. So let's see if we can find that anywhere here. Do you see any lines that may have the little hump that I was talking about? Where you would basically see. Can I make this smaller? I can. We're looking for a P wave, Q, and sometimes you don't see the Q, R, and then a little hump. Then it keeps going. Do you guys see that anywhere? Sometimes it can look like this. Let's see if I can draw it. Like that. You say V1 and V4, you say fourth one down. I see what you mean. So you're talking about fourth one down garbage right over here. You're saying V1 and V4. I like that message, garbage. You're saying V1 and V4, so you're saying like right here, and then you're saying right here. Okay, but the thing is the S wave is not merging in with the T wave here. So you see that the S wave right here, if this is going to be like the Q, this is the R wave, and then this is the S wave, then they're not, the S and the T are not combining. It's not ST elevation over on the V4, right? But if we look right here, we can see the Q, R, and then we see the S and the T wave are combining right here, right? Creating these humps that we're looking for. And so what lead is this? If I erase some of this nonsense that I put on here, how do I erase? Can I not erase? Not a big deal. Let me erase some of this. Get out of here. Get out of here, you. Oh, no. Okay. And so we can kind of see that in lead 2, 3, and AVF. So if we zoom in right here, we can see these humps where the S and the T wave are kind of being combined here. They're being combined here. They're also being combined here. Okay, so we can see it in lead AVF, in lead 3, and lead 2. And so the relevance of finding them in 3 different spots is heart attack electrically can't be categorized as one unless, where is that imagery at? Here it is with this great thumbnail from Nikolay Yusupov. Thank you, sir. It has to be positive in 2 or more of the same regions. Okay, so we can see that it's positive in lead 2, 3, and AVF. Like we had it positive here, here, and here. And these are all our inferior leads. So we need it to be 2 or more. That means if I had ST elevation in, let's say, V1, but not in V2, then it doesn't count as a septal EKG. If I see it in V6, but I don't see it in V5, AVL, and 1 does not count as a lateral ST elevation. But if I visualize it in the inferior leads in 2 or more, like I do here, right? 2, 3, AVF, and this is a very classic EKG, then I can say, okay, this is ST elevation causing a myocardial infarction in the inferior leads. What is this graph called for the inferior anterior? Oh, for this, if you just type in, like, you can Google 12 lead EKG leads or locations, right? So if I type in, oh, hold on, 12, oops, I keep on, 12 lead EKG placement, EKG heart region. If you type in something like this in a Google search, then that tells you kind of more so what you're looking for. Do they have that for 4 lead? You can't detect a STEMI using a 4 lead. However, a 4 lead basically just shows us lead 2, and as you can see, lead 2 is a very abnormal rhythm. This rhythm right here in lead 2 is the exact same extended version of lead 2 right here. They're the exact same rhythm, and if you look, they look exactly the same. This is just a prolonged version. This is what we see in a 4 lead right here. And why do we look at a 4 lead initially, or why do we look at lead 2 in a 4 lead? It's because it basically gives us a great view or like a snapshot of the heart. So if we're looking at the heart in general, heart, let's see if I can find it. This is a pretty good, is this a good version of it? I kind of want it to be tilted a little bit. But basically, lead 2 is great because it's basically like a snapshot from here down to here. It gives us a really good view of that region. It's not really that thick of pen, right? It would be nicer if it was more thick. Okay, so it's basically we're looking at the heart electrically from here to here in a really good view. That's why we like lead 2 so much. And that's why we extend it so much, and that's why we look at it in a 4 lead. Okay, there's also things such as reciprocal leads, where like, okay, these 3 are positive, and then if we look at AVL right here, we can see that the region is basically the exact opposite. So it's showing like a reciprocal lead, or basically an opposite lead. That's the exact opposite of these 3 leads that are positive. This one's it's basically a photo upside down. That's more of a confirmation for us to say like, hey, I think that they're having a heart attack, or I think they're having ST elevation causing myocardial infarction in the inferior leads, helping confirm our diagnosis with the AVL being in the exact opposite. So just something to think about, right? You don't need to master this skill, but as a medic, if you see an EKG like this, you should immediately be like, this is an inferior STEMI. Let's go. Or if you had only the 4 lead, right, and we were interpreting it, and we saw a rhythm like this, the first thing that we're thinking is we need a 12 lead. We need to see more so what's going on, right? And I mean, this is such an obvious 12 lead once you know how to look for it. Like, this is such a huge hump where if you don't see this as a medic, then you should really question your skills, and you should really do a lot of re-education. I don't blame you because it's hard, but you know, this is something that you really need to be able to catch quickly. Okay. Anyway, our EKG, or our 12 lead, if I can take this, our 12 lead presents with ST elevation in the inferior leads in the heart. Okay? So, our patient presents like so. So what's our treatment plan? These are our vital signs. What do you guys want to do? We have our patient, he's freaking out, he has chest pain. He takes a baby aspirin in the morning. He takes simvastatin, metformin, gabapentin. He has chest pain. He was jogging for 30 minutes, felt his chest pain, relaxed for 10 minutes. It hasn't gone away. It's probably been about 20 minutes since we started gathering vital signs and EKG and asking questions. So now we're saying 50 minutes passed, so they've had more than 15 minutes of rest. Hasn't gone away, so it's not stable angina. So what are we thinking for our treatment plan here? What can we do for this guy? How do we want to treat this patient? Any guesses? If not, I'll throw some guesses out in a moment. So, 1 dose of nitro and 324 milligrams, definitely transport. Okay, it's a pretty good treatment plan, right? Give aspirin if not taken. Okay, so if we look back here, we saw that the patient takes a baby aspirin in the morning, right? Rapid transport to a cath lab. Okay, great option. Good to see you, Wes. Great options, right? So what would I personally do? We know that he doesn't have any drug allergies because we asked. We know he takes a baby aspirin in the morning. So if he takes a baby aspirin in the morning and we want to reach the 324, format painter, the 324 dose, let me copy this, of aspirin, how many more aspirins do we want to administer? Do we give all 324 milligrams? Think about it. Because remember, aspirin, Zach, aspirin goes first. Okay? So I agree with your treatment plan, but we want to kind of put in order, like, what do we want to do first? Okay? So how many more aspirins do we want to give this guy? He already took a baby aspirin. How much is a baby aspirin? Does anyone know? And I'll give you guys a couple of seconds to think about it. And so, JJ Cola or Koala, good to see you. So, a baby aspirin is 81 milligrams. We want to administer 3 more to reach 324 milligrams. Oops. Exactly. You're exactly right, Zach. 324 milligrams. So we give him 3 more baby aspirins. So the first thing that we do is we try to stop the problem from getting any worse. We already know he's not allergic to aspirin. We ask past medical history. He doesn't have any gastric bleeds that we know about. Okay, let's give him 3 more to reach 324 milligrams of aspirin. From there, if we're thinking like we're EMTs or AEMTs or paramedics, what do we want to do before administering nitroglycerin? And this isn't a fair question to some of you guys. Some of you guys are EMT-Bs, which is perfectly fine. But if we're an AEMT or a paramedic, we've administered our 324 milligrams of aspirin by giving him 3 more to equal up to 324. What do we want to do first? Okay, so we assess his blood pressure. We have a blood pressure of 146/74. They don't take erectile dysfunction medications, or he's not taking any. Exactly. We want to start an IV, right? We want to set up an IV, have a saline bag hanging. This is for paramedic and AEMT only, right? Where we would want to consider this just because we don't want to dump the patient's blood pressure. From there, though, after we set this up, we administer nitroglycerin sublingually, and we we'll say we do it at 0.4 milligrams or 400 micrograms. You barely have any experience? Oh, garbage. Don't worry about it. This is why we're here, right? We're just talking about EMS calls. So the more knowledge you're getting here, the more you'll be prepared for your school. So don't worry about it, garbage. So we administer nitroglycerin sublingually. We administer 0.4 milligrams or 400 micrograms. Yeah, we're going to learn together. Exactly. Now that we administered that, what do we want to do next? So we administered that medication. What do we want to do? It's just like what we talked about earlier. You and I are both in the same boat. Bio Big Daddy, don't worry about it. Guys, this is exactly what you want to do on basically any cardiac or chest pain call. We want to reassess the patient, right? We reassess the patient. And what are we going to check for our reassessment? Exactly 3 to 5 minutes we want to reassess our patient. What are we checking for our reassessment? Are we going to look at their blood pressure? Are we going to look at their skin turgor? Are we going to look at their presentation? What are some things you guys want to know? Vital signs, right? We want to look at their vital signs, exactly, Wes. So I'm going to copy and paste this over here. And we can ask their pain. Exactly, Wes. We can ask for his pain also. So his pain was initially a 10 out of 10. We're going to say that their blood pressure now, I'm going to do format painter here. Now their blood pressure is 118 over 72 or 70. We're going to say their heart rate still like 110, so still elevated. We're going to say the respiratory rate is now at 18 breaths per minute, which is still normal. Their ETO-CO2, we'll say it's at 40 right now. Now, it's a great thing to assess, Wes. Their pain is now a 1 out of 10, or let's say 3 out of 10 on the pain scale. Okay, so why is this relevant? Why does it matter if we gave nitroglycerin? Their pain was initially a 10 out of 10 because we asked before we administered it, and now their pain is a 3 out of 10. Why do we care about that? There's two thought processes I'm kind of looking for. Why do we care? Right, training better with nitro, vasodilator is working. So this gives us two amazing bits of information. This also works really well with like Narcan, oral glucose, seeing somebody change, right, their presentation. So first off, this tells us that it may actually be cardiac in nature, right? It furthers our diagnosis, our differential diagnosis of a possible heart attack, right? Because, hey, the treatment for heart attacks is working on this patient who may be having a heart attack, right? So it kind of confirms us. It's the same thing with like if we give Narcan to somebody and then we see them responding well to Narcan, well, hey, if we were initially concerned about an opioid overdose, now we're really concerned about an opioid overdose. So it's great information to tell the hospital staff. It's such a good piece of information. Second, it helps our patient, right? It helps our patient, okay? So, and gives us more information. So, first off, of course, or more so, we want to help our patient. So we want to relieve some pain. And reperfusion of the heart, the whole reason why you're having chest pain is because your heart's saying, hey, I'm not breathing. So then we give nitroglycerin to help open it up and help them breathe a little bit better. But second, like we're seeing that our treatment plan is working, so that way we're able to say like, hey, like we're actually doing a good job. Okay? Now, this is for paramedics. Would you call in differently, I'm assuming, now that you've determined chest pain or possible MI? That's a great question. So, somebody mentioned it earlier, how we're going to go straight to a cath lab. We're going to talk about that right now. So, if we kind of go back on this call a little bit, let's say first, how would I route this call? What would I actually do? If this was my patient, I'd get them on the stretcher, moving them as little as possible. After assessing their baseline vitals, asking about sample OPQRST at the same time, because you can do both. You have a partner, right? So one of you gets vital signs, the person who's lead asks about sample and OPQRST. We gather a 4 or a 12 lead. Oops. We gather a 4 or a 12 lead, right? Let's see if I can kind of do this. There you go. So they're already on the stretcher, right? And then we want to, we give them aspirin early on the call. And we try to reach that 324 milligram dosage. So for him, we give him 3 more. Then when we get him in the back of the box, so we set up the stretcher, he's inside the medic unit, work on an IV, finish the 12 lead. Kylie, I need to fix this. No. Yeah. Finish the 12 lead if it isn't done yet. So we're working on an IV, set up a saline bag, and then administer nitroglycerin if indicated, which it was in this call. Then what are we going to do? We're going to set up to go code 3, because this is a heart attack, right? And they need a cath lab. We're going to set up going to code 3 to the nearest cardiac facility. You're not going to do them any justice if the cardiac facility is 20 minutes away, if a normal ER is 10 minutes away, and you go to the nearest ER. Why? Because they need cath lab. And so if you go to the nearest ER because you're like, oh, I'm scared, I don't want to end up hurting my patient, then what's going to happen? As soon as you get there, they're going to be like, oh, thanks for nothing. They're going to request a private ambulance service because you can't transport them anymore. You've already made this decision. They're going to request a private transport ambulance while they're trying to stabilize your patient. And then they will go, it's going to take like 20 minutes for them to get on scene. They're going to go to the hospital and then transfer them to another hospital. It's going to take a long time. So you're just wasting the patient's time. Okay. So we're going to go code 3 to the nearest cardiac facility. I'm going to continuously reassess my patient. They're having a possible heart attack. So it's critical. How often am I going to assess? Am I going to reassess their vitals? If your patient's having a heart attack, how often do we reassess vitals? And you said call medical direction, consider flying them if needed. Possibly, depending on if you're in the county and depending on your local protocols, Wes. That's not a bad answer, but it really is dependent on what your local protocols is. So Wes says every 5 minutes. I think that's a really great answer. The patient is critical, so we will reassess every 5 minutes. That's perfect, Wes. If they weren't critical, we do it at most every 15 minutes where we'd reassess their vital signs. Okay? So let's say their blood pressure is 118/70. Code with sirens would make their situation worse. Technically, but if they're in a 911 call in general, their heart rate's going to be elevated. So Zach, you bring up an awesome point. If we're going code 3 with sirens, honestly, in any 911 call, you should expect your patient's heart rate to be slightly elevated. If I see like 104 beats per minute, I mean, I'm not really like freaking out too much about it. Yes, systemically, what could be going on? There could be a couple things, like they could be in compensated shock, they could be in sepsis or something like that. But at the same time, it would be kind of weird if your heart rate wasn't a little bit elevated, if you're already freaked out to the point where you're calling 911. So yes, that could potentially make it worse, but then that's whenever you, as like the lead, either the lead individual in your medic unit, you're talking to your patient, you're trying to calm them down, because let's say you're already done with your intervention part for the most part. Now you're just reassessing and you're talking to the patient and you're talking to them calmly and you're looking at them in the eye and you're being very confident in your skills and you're like, hey, don't worry, I've got you until we get to the ER, right? So that's whenever we try to show off our confidence in our abilities, okay? It usually relaxes our patient quite a bit. And so, how would my radio report sound? Because this is something that causes a lot of conflict for patients. So I like to go with my mental status starting off. So if a patient was able to answer all of my questions, if they had no issue with responding or to any type of stimuli, they were able to move appropriately, what would I assume that their GCS is? What's their GCS for this patient? I've made no note that they have any abnormal responses. For a patient like this that was able to answer everything. So Wes says 15. Anyone else? Oh my goodness. Oh my goodness, guys. I can start a poll? That's hilarious. What's their GCS for this patient? That's hilarious. Oh my gosh, I had no idea I could do this. Guys, we can do polls. That's hilarious. What happened? Okay. We have 3 votes. That's so cool, guys. I had no idea I could do this. Okay. We're going to end the poll. Everybody says 15. I agree. It's going to be a GCS of 50. Guys, we're going to have to start doing more polls. Insubmitted photography. Good to see you, buddy. Yes, I agree. The GCS is a 15. So, what does my radio report sound like? I would say Medic 71 to Spawn Shoreline. They would say Spawn Shoreline, go ahead. Medic 71. I'm in Corpus. Lime pie, cherry pie in Texas. It's a beautiful place. I love it a lot. Medic 71. We're coming in code 3 with a 31-year-old male patient, GCS of 15. Patient complains of chest pain times 1 hour, 10 out of 10 initially. Vitals, let's see. We administered nitroglycerin 0.4 milligrams. Pain went down to a 3 out of 10. So we're showing them some of our treatment plan, right? Inside my head. Oh, I see. Inside my head. My fault. Photography. I'll answer in a moment, Lime. I'm sorry. I thought you said like live, like where I live at. And sorry. Anyway, we administered nitroglycerin 0.4 milligrams. The pain went down to a 3 out of 10. Aspirin 270. What is it? 3 aspirins were given to reach 324 milligrams. PO. Let's see. Patient vitals are as follows. Then I would say like BP, like whatever we have up here, right? I would say the newest set of vitals. BP 118/70, heart rate's 100, setting at 95%. respiratory rate's at 18, temp is at 98.3, blood sugar is at 86, and ETCO2 is at 40 millimeters per mercury. Vitals are as follows. So I would say their BP, their heart rate, their SpO2, their respiratory rate, their temperature, their blood sugar, their temperature, whichever one. And since I have their ETCO2, I would put that in also. And then I would put 12 lead presents as an inferior STEMI. We'll be at your facility in approximately 10 minutes. Then they'll say, copy that, Medic 71. See you on arrival. And that's how a radio report would go. So let me kind of smooth it out a little bit, and then I'll answer your question line. So Medic 71 is Spawn Shoreline. Spawn Shoreline, go ahead. Medic 71, we're coming in code 3 with a 31-year-old male patient with a GCS of 15. The patient's complaining of chest pain for 1 hour now. The pain was a 10 out of 10 initially. We administered nitroglycerin 0.4 milligrams, and the pain went down to a 3 out of 10. 3 aspirins were given to reach 324 milligrams PO. Patient's vitals are as follows. BP is this, heart rate's this, SpO2 is this, respiratory rate's this, temperature is this, blood sugar is this, and ETCO2 is this. The patient's 12 lead presents as an inferior STEMI. We have an IV 18 gauge on the right AC. We'll be at your facility in approximately 10 minutes. Copy that, Medic 71. We'll see you on arrival. That's exactly what it would sound like. We have an IV 18 gauge in the right AC. Because you know I'm only hitting 18 gauges because I ain't no chump. Unless I have to do like a 20 gauge, then I will. But usually I'll miss with an 18 gauge, then I may consider going down to 20. Okay, so anyway, I hope that kind of gives you an idea of what would happen. And then I would do the same thing with the nurse pass off, where I would tell them basically the same thing about what happened. If you guys want, I can tell you guys what a nurse pass-off would look like. It's very similar to this. But let's see. That's nice. I'm glad. But when do you go live normally on YouTube? It's pretty random. Honestly, I don't have a consistent schedule at this time. But every live that we do is posted on the channel under the live section. What else about it? I work the next 2 days, so it's tough to say when I will next. Can we do the PCR? The PCR? What do you mean by the PCR? What is a PCR? Like a narrative? EMS. Patient care report. Let's see. On your transfer, would you give more backstory leading up to the nature of illness? Okay. See, now, Wes, I can vibe with a question like that. For a PCR, I already hate writing PCRs as is. My narrative would basically just include everything that I have for this one call. I can consider it. But let me see. So the transfer of care, what would I tell the nurse? So I would pull in my patient care report. I see what you mean. Live. And could I go over seizure specifically at the AEMT, what to do if the seizure lasts more than 30 minutes? Also meds used at the AEMT level. Of course, no problem. I can go over that, Zach. Okay, so let's think. Let's say we brought our patient to the ER. Usually everybody is really good about listening, like the nursing staff as well, or the ER nurses staff, as well as the physician. So as I'm transferring the patient, I'm probably going to be surrounded by like 20 people. And I'll say, all right, guys, we're going to transfer the patient, and I'll give you guys my report. So I would literally say that. I would say, all right, I'm going to transfer my patient to the bed. Then I'll give you all report. The patient would probably be moaning at this time, right? And then once we transfer our patient, I'm basically commanding the room for a moment. And I'll say, I have a 31-year-old male patient complaining of chest pain for approximately 1.5 hours now. His pain was initially a 10 out of 10. We administered 0.4 milligrams of nitroglycerin. The patient's pain went to 3 out of 10. We only administered nitroglycerin once. The patients was administered 3 baby aspirins to reach 324 milligrams PO. The patient has an inferior. Oh no, we did a 12 lead, and the patient presented with an inferior STEMI. At this point, I'd have my 12 lead printed out, and I'd hand it to like a physician or a nurse while I'm still talking. Let's see. We have an 18 gauge IV established on the right AC. Vital signs are as follows. Blah, blah, blah. Vital signs. So BP, heart rate, SpO2, respiratory rate, temperature, blood sugar, ETCO2. Patient has no known drug allergies. What else would I say? So we mentioned the drug allergies. Patient, oops. And this is where I can start to talk a little bit about their past medical history. Patient has a past history of 2 stents from 3 years ago. We'll just say I gathered that information. Patient is a diabetic. He takes metformin, simvastatin, and a baby aspirin at home. Oh yeah, also gabapentin. Gabapentin and a baby aspirin at home. Oops. And if I gathered the information, patient's cardiologist is Dr. Zach Pope. And then what else? Patient's cardiologist is Dr. Zach Pope. Patient's PCP is Dr. Wes. That should pretty much be everything that they would need. And then from there, they would get their own EKG, and then go from there. They would be drawing cardiac enzymes with the IV that you established. If you have time, you can set up a second IV on their left hand. We normally like to go from the hand, then the forearm, then the AC, and we'll kind of work our way up. An IV is really great to establish on an AC initially, like during the ER call, but this is going to be a long-term patient, and they can't bend their arm whenever we establish an IV on their AC. So if you're able to do it in their hand or their forearm, then that works really well for our patient. So something to consider. I hope that kind of gives you guys kind of like a little rundown about the whole transfer of care. For my PCR, you want a PCR of this call too? Oh, brother. Oh, brother. It's gonna be a long PCR is the thing. Um, I would say something like Medic 71. Some people like to use the DART formula. I kind of write my own PCR. But yes, Wes, I think so. And by the way, this is going to be saved. I publish all my YouTube lives, and I have this one with kind of like a different thumbnail. This is live EMS practice scenarios number 5. So if, yeah, right, don't make me write a report. I'll give you a general idea at least, because it's a great question, Lime. It's a really great question. But this is going to be live or published. So if you're ever curious about a radio report, if you're ever curious about a transfer to the hospital staff, you can always revisit this video. And you'll be able to see your own comments because I try to make it included in the video. That's why I have the chat popping up on the actual video. But you'll be able to review it. And then you'll be like, oh, this is the question I asked, and so forth. So it's pretty good study information, in my opinion. What are some quick things that I would write really quick, though, if I had to? Medic 71 was dispatched to 1111 Mario Drive for a chest pain call. Medic 71 arrived on scene and walked into the patient's residence, located a patient, a male patient, sitting down on a recliner. The patient appears diaphoretic, just means sweaty. The patient advises that he was jogging outside times 30 minutes ago. Actually, 40 minutes ago. Or I would just say times 30 minutes. When he began experiencing chest pain, called EMS after waiting 10 minutes. Since the chest pain didn't dissipate, the patient, Medic 71 began assessing the patient's vitals and 12 lead. The patient advised that he took 81 milligrams of aspirin in the morning. Patient was administered 3 more baby aspirins to reach 324 milligrams of aspirin. The patient, let's think here. The patient was, there's something else that I wanted to put here. Patient was, oh yeah, has a past history of 2 stents placed 3 years ago from a previous MI. The patient's cardiologist is Dr. Zach Pope. So this is just other information I'm grabbing, right? The patient's PCP is Dr. West. Let's see. So the patient was assisted to the stretcher and secured via guardrails. I'm already so far, right? And I'm never doing this again, by the way. Straps. The patient was loaded into the ambulance without incident. I'll probably move up a little bit right here. The patient's 12 lead presented as an inferior STEMI. Let's see. The patient was loaded into the ambulance without incident. An IV was established in the patient's right AC 18 gauge, and a saline bag was hung but not utilized during this call. The patient was transported code 3 to Spawn Shoreline. Let's see. Did I already mention the nitroglycerin? I did not. The patient's pain was initially a 10 out of 10 on the pain scale. Was administered 0.4 milligrams of nitroglycerin sublingually. Patient's pain went to a 3 out of 10 on the pain scale. Patient's vitals were reassessed approximately every 5 minutes. Spawn Shoreline was contacted early prior to EMS arrival. Upon our arrival, the patient was taken to their assigned room. Patient report was given. All signatures were obtained, and patient care was transferred to nursing staff. Medic 71 returned to service. Ah, I hated that. Here you go. Here you go. You know what? Here you go. Oh, it's too many characters. You should have access to this. Oh my gosh. My message is too long. Wah, 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 wah. Let's see. Let's do this. Let's do this. Oh, no problem, buddy. I have no problem with that. Okay, let's do this. Let me do you a favor, though, to make this very easy for you. Okay, first off, I'm attaching all three of these into the Discord. But to make this easier, do you have a notes section on your iPhone? Do you have a notes section on your iPhone or somewhere where you can copy and paste info? This is the, oh my gosh, I can't upload anything. Use worthless. This is worthless. What can I do for you guys instead so you guys can have this? All three of these are typed out in the Discord. But is there another thing I can give you guys access to? Something that may help you in some way? No, I'm just gonna put it in the Discord. If you're not in the Discord, sorry. Here's the here's the Discord link. If you would like to access what I just typed up, and let me edit it so that it's unlimited. Generate new link. Let me do this again. There you go. Okay. If you want access to all this typed up to where you can copy and paste it later or use it as notes, that is a link to the Discord. Okay? And that gives you a fantastic lime. I saw that you joined in. I'll give you a little wave. Hello. You guys have access to this now. You guys can access what I typed up. And I will reference this if anyone ever asks me to do this again, because I already hate writing reports as is. But it's really important for your general knowledge. So I'm glad to type it up for you guys. That's how I would write this report. That's how I would do this report. That's how I would do everything for this call. I hope it helps you guys. And now my hand hurts. Damn it. It's okay. It's good knowledge for you guys, though. What's something else we can do? Anything else besides this? Zach says, could you go over seizures, specifically at the AEMT level? What would you do in a seizure that lasts more than 30 minutes? Great question. When does a seizure indicate epilepsy? That's a great way to start this. I think it's greater than 10 minutes or 20 minutes. No. I have this written down somewhere. No. It's at a certain time limit. Is it 10 minutes? Is it 15 minutes? Maybe ChatGPT knows. ChatGPT. I've trained you, ChatGPT, from talking to you in the past. How long would a seizure have to last to be considered epilepsy? I misspelled that, but you should get what I'm saying. Thinking longer for a better answer. Thank you, ChatGPT. Let's see what it says. Come on. It's relevant info. Just join in as well in the Discord. Oh, hey, Morgan. Good to see you. Thanks for the Discord. No problem. Good to see you, too. Good to see you. Let's see. Epilepsy lesson 24 hours. They say 5 minutes is the cutoff. That's not true. I think it's like 10 or 15 minutes. I think it's like 15 minutes for a seizure. But we're going to kind of ignored it. Just joined as well. Thanks, Mario. The Discord, I mean. Fantastic, Morgan. Fantastic, Zach. Okay, anyway. So there's a certain point where we're concerned about epilepsy. Whenever it comes to a seizure patient, I'm reading somewhere where it says 2 seizures at once. I know that it's more so in regards to a patient who has what is it called? Where they're having a seizure for X amount of time, but I cannot find the actual info. I know I have it somewhere, but I can't pull it up right now, unfortunately. I know how I pull it up, but I don't want to pull it up on stream. I'll wave to you guys too. Hello, hello. Anyway, for a seizure patient, regarding AEMTs, what can you do? What can you do as an AEMT? What can you do as an EMT-B? Right? So as an AEMT, what can we do for seizure patients? Let me ask you guys that. As an EMT-B or an AEMT, what can we do for a seizure patient? Think about it. Can we offer them a labubu? No, the labubus are for us. I saw somebody has a profile picture of a labubu. That's hilarious. I'm going to pin these. I'm going to pin this one too. Does anybody know what we can do if we're an EMT-B or an AEMT and we have a seizure patient? I'll give you guys a second to think about that. Think about it. What can we do? Can we do anything? Protect the airway. Okay. So protecting the airway. How do we protect the airway of a seizure patient? So Zach says we can protect the airway. Any other guesses? I'm about to give you guys the answer. Realistically, squat. You can't do nothing. You're not putting an OPA or an NPA in a patient that's having a seizure because they're going to be jerking around the whole time. We can't do anything for them if they're having a seizure. What can we realistically do? We can move stuff out of the way. We can move stuff out of the way. That's it. I mean, that's pretty much all we can do for a seizure patient. So what do you need to do if you have a seizure patient? Should we wait 10 minutes? Should we wait 20 minutes? See if the seizure gets better? If we have a seizure patient, what should we do? We can only move stuff out of the way. Because we don't put things in a patient's mouth anymore. Because they can potentially choke on it. You don't put like a towel inside their mouth because they could potentially gag on it and start puking and choking. So we move stuff out of the way. Then what else can we do as an AEMT or an EMT-B? Well, we request ALS intercept. Specifically, we request a paramedic. A paramedic can administer a sedative like Versed, Valium, or mag sulfate, depending on the complication and depending on how they want to go about it. They administer Versed either IM, IV, or intranasally. They administer Valium, or also known as diazepam, intravenously. You don't administer it intramuscularly or intranasally because it's water soluble and it won't properly pass through the patient's body to interact with what we need it to. Mag sulfate is reserved for pregnant female patients or just pregnant patients, right? That way we don't harm the baby as much as we would if we gave them Versed or Valium. Why couldn't an AMT have the scope for one of those medications? National registry wise, you do not have access to this. A paramedic has access to this. Now, depending on the agency you have, your medical director may say, hey, you know what? You've been here for X amount of years or X amount of time. You've done this training. We don't have any paramedics, so we're going to give you access to this medication. But unless that's the case, you don't have access to this medication. This is a paramedic only medication. So we want to request ALS intercept. Well, that's a great question though, Zach. Why can't you have access to these? I don't know. It's just how the education is currently structured for those certifications. But we request ALS intercept, and we request ALS intercept as soon as we recognize a seizure. Some seizures will be like 3 in a row, and they'll be 10 seconds each. Some seizures will last 20 minutes plus. We don't know how the seizure is going to act. Because we don't know how it's going to act, or if we're going to have another one that's going to be prolonged while we go to the hospital, err on the side of safety and request a paramedic or ALS intercept. Okay? So we request ALS intercept. We request for a medic, and they can administer a sedative. They can, while you're waiting, you can try to set up an IV. That would help a lot on your seizure patient. And you may say, how am I going to start an IV on a patient? I would kind of like press down. I would have my partner holding their arm while I'm starting an IV, so that way they can administer their Versed or Valium immediately. So an AMT or an EMT-B, depending on their medical director, can at the very least request ALS paramedic intercept. You're not useless. You still have a job to do. First off, calming the family, moving stuff around. You're the first interaction, so you're the first one to recognize it, which is very valuable. An AMT, for instance, can start an IV. And depending on your local, I'm not going to write it down, but depending on your local protocols, an EMT-B can also start an IV on this patient, right? And so we can start an IV, so once they get in, they're like, oh, thank you for starting an 18 gauge or 20 gauge on our patient. They can administer the sedative and stop the seizure, right? Because every time or every moment that they're seizing, they're not properly perfusing to their whole body. They're building up a lot of lactic acid, and that can be really detrimental depending on how long it is. You can also gather information. You can gather information like, hey, does this patient have a past history of seizures, of epilepsy? Did they take a maintenance medication? Did they take it today? What's it called? It's called Keppra. Okay, let's write it down. Who's their neurologist? Let's write this down so that whenever the paramedic shows up, I can hand them a paper or a glove that I wrote on that says their allergies, their medications, their past medical history, who their neurologist is. I can gather like what their baseline vitals are and try to obtain that to the best of my ability. It's tough because it's a seizing patient, but you can do that. I can get the family's phone number if they're not going to go with us to the hospital. What's the patient normally like whenever they're off of the seizure? Because let's say they have a seizure and then you stop the seizure, and then we go to the hospital and the patient their left lip and their left arm is kind of dangling. They're not able to move it, and they have an altered mental status. Is that what they're normally like? So we can ask them, hey, what's their norm like, right? And if we figure out that the norm is that they had a stroke in the past, and that's kind of what's causing these seizures, gathering that info for the medics before they show up is such a huge burden lifted. And it's such a valuable asset to the team. You're really helping out the team when you do that. So EMS is a team game, you know. Everything that you gather and can relate to the medics is one less thing they have to gather. And it's all about your competency and what you can think of asking while you're waiting for a medic. But we want to err on the side of safety. We don't want to wait for a medic to show up on scene. Instead, we want to be proactive and call for 911, call for intercept, and go from there. You also asked what medications an AEMT can administer. That's a tricky question. So an AEMT can administer all the medications that an EMT-B can administer. They can also administer medications like, before I forget, nitrous oxide for pain management, where the patient inhales it spontaneously on their own to provide their own pain relief. We don't carry that in where I work at, but some fire departments do carry that, especially up north. More patients or more departments carry it. Uh, you can administer ondansetron, which is Zofran. This is for AEMTs right now, but we're kind of doing a mix of EMT-Bs, AEMTs, paramedics. We're kind of giving you just a little bit of everything, but this is more so the scope of an AEMT. So an AEMT right now, they can administer nitrous oxide, but it's good to see you see. They can administer ondansetron. You can administer dextrose via IV. You can administer saline. You can administer glucagon via IV. So there's some of the medications that you're able to administer as an EMT-B. You can gather EKGs, but you can't interpret them. You can. There's a couple other things, but those are primarily the main things that you're able to do as an EMT. Let me check something. Hold on, my sweetheart is calling me, so give me a second. Hello. Can you guys hear me again? Let me see here. Okay, I still got a tiny bit of time. I wanted to do a quick practice question or two with you guys, and then we're going to head out. So I did some of these practice questions beforehand on our last live, but I'll just go with it with you guys. This is on amateurmedicine.com. If you're practicing or preparing for the EMT-B, then this is a great resource for you. Unfortunately, we're not done with our AEMT portion yet. Oh, thank you so much, Morgan. But just kind of like a food for thought. So we are treating a patient with an isolated closed mid-shaft femur fracture. Which of the following are correct regarding the use of a traction splint? So this is on amateurmedicine.com. Which answer choices do you think are correct? Oh, no problem. And if you're looking for more practice questions, you can always find it on that website. There are some sample questions that you can access for free. But if you do decide to purchase the study bundle, you have access to quite a bit of a library. But what do you guys think is correct here? You're treating a patient with an isolated closed mid-shaft femur fracture. Which of the following are correct regarding the use of a traction splint? So we have the traction splint is indicated for closed mid-shaft femur fractures without major injuries. I agree with that. We don't apply a traction splint on an open femur fracture. The traction should be applied until the patient feels slight discomfort. That's technically incorrect because we don't want to cause any discomfort to our patient. We want to stop whenever traction is properly applied and the patient feels relief. You should apply a traction splint even if there's an open fracture. That's incorrect. We don't want to do that because we don't want to cause the bone fragments to potentially puncture an artery and cause an arterial bleed. You should check a distal pulse motor sensation before and after application. That's correct because we want to see if our application is helping or our intervention is helping or if it's actually making the scenario worse. And the traction should be applied to realign the bone and reduce bleeding. That's correct. So All of this is correct. For the traction splint, it should be applied until normal limb length and a comfortable amount of tension is achieved, not until the patient complains. An open fracture is contraindicated for a standard traction splint use. So now we can utilize our pole function. You have a 31-year-old female patient who has left upper quadrant abdominal pain and left shoulder pain. What diagnosis can you differentiate with just these two symptoms? No more than 15 pounds, right? Are you talking about of traction pressure? Honestly, I'm not sure photography. But let's do a poll here. Oh, there's a Q&A? Dang it, I didn't even know that was a function. You have a 31-year-old female patient who has left upper quadrant abdominal pain and left shoulder pain. What diagnosis do you suspect? Okay, I only have so many things that I can put in here, but let's see. Is it ectopic pregnancy? Is it gallbladder inflammation? Is it splenic injury? Or is it pancreatitis? Which answer choice is correct out of the four? It's okay, you can guess. But those are your options. What are we thinking? So 31-year-old female patient who has left upper quadrant abdominal pain and left shoulder pain. Oh man, this whole poll thing is super cool. I like it a lot. Any other guesses? We're about to end the poll. Throw in your guesses if you can. You've got another 15 seconds. I'll give you a hint. Everyone's getting it wrong. But that's okay. That's why we're talking about it now. 5 more seconds. 5, 4, 3, 2, 1. And the answer choice is, it's okay. It's good to guess, RDL. Is a spleen injury. Wondering if you wouldn't mind coming and talking about my club and a bridge program, blah, 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 blah. Of course I would love to do that. Okay. It is a spleen injury. Whenever you see left upper quadrant abdominal pain and left shoulder pain, at least regarding the EMT-B, should be a freebie. You should automatically think that it's the spleen. Okay? So if you guys have a National Registry question and you see, C says C, excellent. And you see left upper quadrant abdominal pain, you see left shoulder pain, I honestly turn off your brain. Look for the answer choice that says spleen injury and then go from there. Okay, these two go in conjunction with the spleen injury. Don't worry about it. Better that you miss it here than you miss it on the National Registry, right? Ectopic pregnancy typically localizes the pain to the right lower quadrant or left lower quadrant, includes vaginal bleeding. Gallbladder issues like cholecystitis has right upper quadrant abdominal pain with right shoulder pain. Pancreatitis is central upper abdominal pain, sometimes radiating to the back, not the shoulders. So, let's do another one. And I'll start a poll. You are assisting with a delivery when you observe a single arm presenting. What should you do? Should you attempt to pull the limb and assist with delivery? Should you push the limb back inside and attempt to reposition? And YouTube is only giving me so many like characters to use. Should you discourage further pushing and transport immediately? Or should you proceed with the delivery normally and wait for the rest of the baby to deliver? So what do you guys think? RDL says C. Don't worry about it, RDL. You're fine. Any other guesses? So we are assisting with the delivery of a newborn. When we see a single arm presenting from the birth canal, what is the most appropriate action? Should we attempt to gently pull the limb and assist with delivery? Should we push the limb back inside and attempt to reposition the baby? Should we discourage further pushing and transport immediately? Or should we proceed with delivery normally and wait for the rest of the baby to deliver? So we have 4 votes so far, and all 4 votes say to discourage further pushing and transport immediately. Gee whiz, what's the right answer? I got a good feeling about this one. I'm going to go ahead and pick what you guys are saying. And that's correct. Good job, everyone. So, a limb presentation, a single arm or leg is a true OB emergency. Don't attempt to deliver. Support the exposed limb gently. Discourage the mother from further pushing and transport rapidly to the hospital with surgical capabilities like needing a C-section. Good job, guys. Good job. Do not yank that baby out. Last question, guys. We're choosing one answer only. You're dispatched to the residence of a 70-year-old patient with crushing chest pain. They take lisinopril, simvastatin, Viagra 10 hours ago. His BP is 132/78, and he has a nitroglycerin prescription. What should you do next? So, I'll let you guys think about it. Oh, geez, a lot of sounds going off on my phone. Hello? Okay, sorry, I had to answer that. Let's see. What's the right answer? Should we administer aspirin to this patient? Should we administer nitroglycerin? Should we administer both? Glycerin? Or should we administer oxygen or administer high flow oxygen? What's the correct answer choice for this patient? We are dispatched to the residence of a 70-year-old male patient with crushing chest pain. They advise that they took lisinopril, simvastatin, and Viagra approximately 10 hours ago. His BP is 132/78, and he has a nitroglycerin prescription. What should you do next? Shane. Oh, hey, Shane, what's going on? You passed your NREMT yesterday? Oh, good job. Congratulations, Shane. I will throw hearts out for you. Good job, good job. That's what we love to see, Shane. Fantastic work. Sounds like you worked very hard. But this is going to be our last question, Shane, but what a great way to end it. I'm very proud of you. Sounds like you worked very hard. Anyway, so we have some people that voted for aspirin, some that voted for nitroglycerin, and some that voted for high flow oxygen. All great choices. Let's talk about it though. So the answer is going to be aspirin. Why is it going to be aspirin? The patient has crushing chest pain. Their blood pressure is within the normal range. However, they took Viagra approximately 10 hours ago. That means that, and congratulations, Morgan. I think I remember you passing and telling me about it, so great job. For a patient that takes nitroglycerin, or if we're considering administering nitroglycerin for a patient, we're worried about erectile dysfunction medications within the last 24 hours. One of them includes Viagra. So since they took this 10 hours ago, we can't administer nitroglycerin. We can, however, administer aspirin, unless contraindicated otherwise by a GI bleed or from, what is it called? From a GI bleed or if they're allergic to aspirin. So, great job, fellas. You did a fantastic job. Beautiful work. And we're going to get out of here. Whoa. You got to pay for this. Let's see. Congratulations, Morgan, again. Have my NREMT Tuesday, super nervous. I've been taking pocket prep and have been doing the best. Any suggestions? What would I suggest before I head out? I would suggest checking out amateurmedicine.com. We have a fantastic study bundle. It can help you. Buddy, if you're taking it tomorrow, though, I would recommend just watching my EMS study guide video for the NREMT. I think that'll help you out a lot, RDL. But if you do have the time and you're looking for a study bundle, or for your friends looking for a study bundle, you can always recommend the one we have at Amateur Medicine. It's a great bundle. It has access to 120 practice questions for your vital signs, 500 practice questions for your EMT-B with a with some practice exams, practice questions for your GCS, APGAR, and Rule of 9, and a 26 PDF that's completely filled out for you that you're able to utilize to study. The test is very hard, Jimmy. I failed both times at about 100 points. Don't worry about it, Jimmy. It happens. I failed my NREMT-B twice and I passed on my third try, so I completely sympathize on what you're experiencing. I'm going to go ahead and head out now, but if you guys have any other questions, you can always message me in Discord. What time do you normally start your live streams? I always catch you when you're about to be off. Honestly, I would turn on notifications for YouTube. I can't give you a solid time, but maybe I'll make a note of the next time in like our post on YouTube, or maybe I'll mention it in Discord or something. But because of my work and my school and nursing, I can't really give you a definitive time. See, it's really just when I'm available. But you can enable notifications on YouTube. I won't be able to do it for sure for these next 2 hours or for these next 2 days because I'm working. But I'll try to do so in the future and give you guys a little bit of heads up. Sorry about that. But I'll try to notify you all in the Discord and a post on YouTube. But I'd recommend enabling notifications for the future. That'll help you out, at least if you're trying to reach me. But with that being said, guys, I'm going to go ahead and head out. Thank you all for stopping by. And I'm going to post this live on YouTube. So if you want to revisit some of the stuff that we talked about, it's all going to be there. But I'll see you later. See ya. I really like pressing all these buttons. It's really fun on the computer. These really help me. Thanks again. See you, Morgan. And that's great to see. Great to have you. I don't. What is the point of any of these? These are just kind of funny, right? Okay. I'll see you later.